Usually when we talk about a medical diagnosis, there is an expectation of precision. It feels like, well, like engineering in a way.
Right, very mechanical.
Exactly. A patient breaks a femur, the orthopedic surgeon points to the jagged white line on the x-ray, and there is just zero ambiguity.
You can see the problem right there in black and white.
Yeah, and we fundamentally crave that clarity. We want our medical science to be visible, cleanly categorized, and entirely predictable. But the moment you step into the world of trauma, neurodevelopment, and especially psychiatric prescribing, that x-ray machine becomes entirely useless.
It really does. The visual certainty just vanishes. And you are left navigating what is, arguably the most complex organ in the known universe.
Which is incredibly daunting.
Oh, absolutely. When you are the clinician holding the prescription pad, trying to chemically regulate a nervous system that has been fundamentally rewired by terror, that lack of an X-ray can feel incredibly isolating.
Which is exactly why we are dedicating this entire session to you, our listener. You reached out and specifically asked us to compile a deep dive tailored for your daily clinical reality.
Right, the stuff you actually deal with in the clinic.
Yes. As an experienced psychiatric nurse practitioner, a psychiatric trainee, or an advanced prescriber, you told us to skip the basic DSM-5 textbook definitions.
You already know the criteria. You see these patients every single day.
Right. You asked for advanced prescribing logic. So we gathered a very specific stack of sources for you today. We are pulling heavily from Stahl's Essential Psychopharmacology, the Maudsley Prescribing Guidelines, the latest VA and DoD clinical practice guidelines for PTSD, and several recent meta-analyses looking specifically at neurobiological treatment resistance.
And our mission today is to translate that dense pharmacological literature into actionable clinical strategy.
Because theory is great, but you need to know what to write on the pad.
Exactly. We are looking at PTSD strictly through the lens of medication targets. This is PTSD Pharmacology Lesson 1, basically foundations of medication treatment.
So we're getting right into the neurobiology.
We have to.
Right.
We need to view this condition not as a collection of behavioral checklists, but as a severe neurobiological disorder of dysregulated circuits.
A structural issue.
Yes, a structural and chemical issue where the brain's fundamental threat detection hardware is locked in the on position and, well, the software designed to shut it off is just completely crashed.
I want to visualize that hardware for a second, just to ground it. If we imagine the human brain as a massive high-security facility, treating PTSD feels less like treating a disease and more like managing a catastrophic security failure.
That's a great way to put it.
Right. Like, we are essentially dealing with a hypersensitive, malfunctioning fire alarm that triggers at the slightest wisp of smoke, combined with a security guard who is supposed to monitor that alarm but has, fallen completely asleep at the front desk.
And that structural analogy maps perfectly onto the neuroanatomy you're targeting when you write a prescription.
So break that down for us. What is the fire alarm?
The malfunctioning fire alarm is the amygdala, specifically the basolateral complex of the amygdala.
Oh, eh?
In PTSD, it is hyperreactive and constantly outputting fear signals. And the sleeping security guard, that's the ventromedial prefrontal cortex.
So what's supposed to happen in a healthy brain?
In a healthy nervous system, the prefrontal cortex assesses the alarm, realizes there is no actual fire, and sends an inhibitory signal down a bundle of white matter called the uncinate fasciculus.
Basically a cable connecting the two.
Right, a white matter highway. And that signal physically quiets the amygdala.
But in the traumatized brain, that top-down inhibition is offline.
Completely degraded.
So as prescribers, we are stepping onto a battlefield where we have to simultaneously muffle a screaming alarm and, well, jolt a sleeping guard awake.
Which is not an easy task for a single pill.
Definitely not. If we are looking at this logically, we need to map our medications directly to these specific misfiring circuits. Let's start with the alarm itself, the profound amygdala hyperactivity.
So the clinical presentation of that hyperactive amygdala is the patient who, jumps out of their skin when a door slams.
Or the patient who absolutely cannot sit with their back to the door in a restaurant.
Exactly. The amygdala is processing ordinary environmental stimuli as lethal threats. It's perceiving a predator.
So how do we target that pharmacologically?
From a medication standpoint, our primary target here is to enhance the brain's intrinsic inhibitory signals. We are looking to leverage neurotransmitters like serotonin and GABA to fundamentally suppress that excessive fear output.
Because we can't just talk the amygdala out of it.
No, you cannot reason with the amygdala. It doesn't process logic. You have to chemically dampen its reactivity.
And while we are trying to dampen that reactivity, we also have to address the other side of the equation, right? The prefrontal cortex hypoactivity.
The sleeping guard.
Yeah. The patient sitting in your office might be fully aware that they are perfectly safe in a grocery store, but their body is reacting as if they are in a literal war zone.
Because their logical brain, the prefrontal cortex, is failing to regulate the emotional brain.
Right. So because that top-down executive control is underactive, our medication target in the prefrontal cortex has to be completely different than in the amygdala.
We do not want to suppress activity here at all.
We'd want to amplify it.
Exactly. Specifically, we aim to boost dopamine and norepinephrine in the prefrontal cortex.
Catecholamines.
Right. These are the catecholamines that fuel working memory, sustained attention, and executive function. By waking up the prefrontal cortex, we are giving the brain the chemical currency it needs to process the fact that the environment is actually safe.
Now, this brings up a massive clinical paradox that we see prescribers struggle with all the time.
Oh, the norepinephrine issue.
Yes. You just mentioned that we want to boost norepinephrine to help the prefrontal cortex do its job, but systemic norepinephrine excess is one of the core drivers of PTSD symptomatology.
Is the primary fuel for the hyperarousal.
Right. We are talking about the locus coeruleus, the brain's main norepinephrine factory, just dumping adrenaline into the central nervous system.
And it forces the clinician to hold two competing realities at once. The locus coeruleus is profoundly hypertrophied in severe trauma. I mean, it is physically enlarged and firing continuously.
Creating just a massive systemic flood of norepinephrine.
Yes, and this is the physiological driver behind the terrifying nightmares, the resting heart rate of 100 beats per minute, the sweating, and the sheer panic attacks.
The autonomic nervous system is acting as if a predator is currently in the room.
Exactly.
So if the peripheral body is drowning in norepinephrine, our target has to be cooling that system down, right?
Yes, we need agents that will eventually downregulate those noradrenergic receptors.
The beta-1 and alpha-1 receptors.
Right, so the physical body stops amplifying the brain's terror.
Which leaves us needing a master regulator to balance all of this out.
We need a system that can basically do it all.
Right, tell the amygdala to quiet down, tell the prefrontal cortex to wake up, and tell the locus coeruleus to stop flooding the engine.
And that master regulator is the serotonin system.
The great balancer.
Exactly. Serotonergic neurons, which originate in the raphe nuclei, project their axons like a vast net over all these critical structures. They project to the amygdala, the prefrontal cortex, the striatum, the thalamus.
Or they touch everything.
They really do. When the serotonin system is dysregulated, the entire orchestra plays out of tune.
And this is where the logic of prescribing seems incredibly straightforward at first glance.
That seems almost too easy.
Right. If serotonin is the great regulator and it reaches all these crucial areas, the immediate instinct is to just give the patient a massive dose of a serotonergic drug.
Flood the synapse with serotonin on day one.
Exactly. Fix a regulation and send them on their way. But anyone who has ever prescribed an SSRI to a trauma patient knows that a massive initial dose doesn't cure them.
It usually sends them straight to the emergency room with a severe panic attack.
Yeah, the pharmacology of why that happens is fascinating, and it is entirely counterintuitive.
It really is. The therapeutic benefit of our medications has absolutely nothing to do with the immediate day one boost of synaptic serotonin.
Wait, really? Because that's what we're taught, right? Serotonin goes up, patient feels better.
That's the simplified version, but it's wrong for PTSD. When you acutely flood the brain with serotonin, you stimulate every single serotonin receptor subtype indiscriminately.
Even the ones we don't want to stimulate.
Exactly. That includes the 5-HT2A and 5-HT2C receptors. Activating those specific receptors acutely drives agitation, insomnia, restlessness, and profound anxiety.
So you are essentially pouring gasoline directly onto the faulty fire alarm.
You are amplifying the noise. You are making the amygdala hyper-react even more.
Wow. So what is the actual mechanism then?
The true clinical magic of these medications relies on long-term receptor adaptation.
The structural changes.
Yes. The brain operates like a highly sensitive thermostat. When you sustain that artificially elevated serotonin level over days and weeks, the brain recognizes the excess signal.
It realizes it's too hot in the room.
Exactly. And in response, it begins to physically downregulate and desensitize its own serotonin receptors.
We are talking about a structural remodeling of the neuron itself.
Specifically, we are talking about the 5-HT1A sodadendritic autoreceptors on the presynaptic neuron.
The brakes.
Right. These autoreceptors act as the brakes on the serotonin system. When they detect too much serotonin, they shut down further release.
Okay, so what happens under an SSRI?
Under the constant bombardment of an SSRI, these autoreceptors eventually desensitize and disappear from the cell surface. They just retract.
And when those brakes are finally removed?
The neuron can sustain a massive, regulated, continuous release of serotonin that finally begins to modulate the amygdala properly.
So it's not the initial flood, it's the removal of the brakes weeks later.
Exactly. It alters intracellular signaling cascades, influences gene expression, and promotes the synthesis of brain-derived neurotrophic factor, or BDNF.
We are changing the physical architecture of the brain.
And that is not a process that happens overnight.
That biological reality is the perfect transition to how we actually utilize the front line of our pharmacological arsenal. Because serotonin and norepinephrine are the primary levers we have to force this structural remodeling, let's dive deeply into the mechanisms of our first-line tools.
Let's start with the selective serotonin reuptake inhibitors.
The SSRIs.
With the SSRIs, the mechanism begins at the serotonin transporter, the SERT pump.
Okay, the vacuum cleaner.
Right. The presynaptic neuron uses this pump to suck serotonin back out of the synapse to be recycled. By blocking that vacuum, we force the serotonin to pool in the synapse.
But keeping Stahl's principles in mind, the goal isn't just a chemical puddle, right?
No, it's the delayed downregulation of those 5-HT1A autoreceptors we just discussed. That is the cascade that ultimately dampens the basolateral amygdala's hyperreactivity.
It is a profound test of patience for both the clinician and the patient.
It really is. The waiting game is tough.
But sometimes muffling the alarm with an SSRI just isn't enough. Sometimes we need to actively wake up that prefrontal cortex.
And that is when we turn to the SNRIs.
The serotonin and norepinephrine reuptake inhibitors.
Here, we are blocking both the SERT pump and the NET, the norepinephrine transporter.
And this is where the neuroanatomy gets incredibly interesting.
The role of the NET in the prefrontal cortex is, I think, one of the most vital clinical pearls a prescriber can master.
Lay it out for us.
When you block the norepinephrine transporter, you are obviously leaving more norepinephrine in the synapse. But in the prefrontal cortex, you are also massively boosting dopamine.
Wait, that feels like a glitch in the matrix.
Okay.
How does a drug designed to block a norepinephrine vacuum end up causing a surge in dopamine?
It comes down to evolutionary biology and the unique architecture of the prefrontal cortex. Most of the brain uses the dopamine transporter, the DA, to clear dopamine. But the prefrontal cortex is designed for sustained, high-level abstract thought and working memory.
It needs the dopamine to stick around longer.
Exactly. It needs dopamine to linger a bit longer to maintain a strong signal-to-noise ratio. The D acts entirely too fast for this area.
So what did the brain do?
Evolution essentially stripped most of the DATs out of the prefrontal cortex. Instead, dopamine relies on the norepinephrine transporter to be cleared away.
So the NET is essentially moonlighting. It is pulling double duty as the vacuum cleaner for both norepinephrine and dopamine in the front of the brain.
Exactly. The NET has a high affinity for dopamine.
Yeah.
So when you administer an SNRI and block that specific transporter, dopamine has nowhere to go.
It just pools.
It pools in the synapse alongside the norepinephrine. You are forcefully pumping the exact catecholamines the prefrontal cortex needs to wake up, engage executive function, and exert top-down control over the limbic system.
You are creating the neurochemical foundation for fear extinction.
Right. The prefrontal cortex finally has the fuel it needs to look at a trauma trigger, realize it belongs in the past, and tell the amygdala to stand down.
But, and we have to circle back to the paradox we highlighted earlier, if excess norepinephrine from the locus coeruleus is causing the nightmares, the panic, and the sweating.
How can a prescriber ethically justify giving an SNRI that increases norepinephrine even more?
Exactly. Aren't we making the hyperarousal worse? Throwing more gas on the fire?
In the short term, yes, you absolutely can make it worse.
Which is terrifying for the patient.
It is. The initial weeks of an SNRI trial in a PTSD patient can be incredibly rocky. The patient might report increased jitteriness or a massive spike in autonomic arousal.
But we are playing the long game.
We are relying on the exact same principle of receptor adaptation that we use with serotonin. We are playing a long game of receptor downregulation.
We are trying to break the receivers.
That's a great way to think of it. We are bombarding the postsynaptic beta-1 and alpha-1 adrenergic receptors with so much norepinephrine that the brain assumes the environment is simply permanently loud.
So it puts in earplugs.
In order to protect itself from overstimulation, the postsynaptic neuron literally internalizes its receptors. It pulls them inside the cell membrane.
Wow.
By week 8 or week 12 of an SNRI, the patient might still be producing norepinephrine, but they have drastically fewer receptors available to catch it.
The physical capacity to feel panic is significantly reduced,
Exactly. The hardware has been modified.
which fundamentally shifts how you manage the patient sitting across from you. If you know that the therapeutic effect requires weeks of structural receptor remodeling, you cannot promise them a quick fix.
Never promise a quick fix with PTSD.
Right. We have to dive into the reality of treatment goals and the severe limitations of our current pharmacology. When a patient walks in completely shattered by trauma, what does a fully optimized SSRI or SNRI trial actually achieve?
Expectation management is the absolute cornerstone of trauma prescribing. If the patient believes the pill will erase the memory of the assault or the combat deployment, the treatment will fail.
Because they will view partial relief as a total failure.
Precisely. What the data actually shows us is that optimized pharmacology provides robust improvements in mood and irritability.
So the explosive anger softens.
Yes, the depressive anhedonia lifts, and we see moderate improvements in hyperarousal.
The resting heart rate comes down.
The resting heart rate drops, the exaggerated startle response is blunted, and the constant vigilance is dialed back to a manageable level.
But the core of the trauma, the intrusive symptoms, the flashbacks, the nightmares, those rarely disappear entirely with a pill alone.
They don't. They might become less frequent, or they might lack the same visceral, gut-punching emotional intensity, but the memory remains completely intact.
And sleep improvements are often entirely indirect.
Right. As the systemic hyperarousal drops, the patient might fall asleep faster, but the architecture of their sleep is still severely fragmented.
The critical truth every clinician must communicate is that psychiatric medications are symptom regulators, not cures.
They are simply turning down the volume.
Let's look closely at the neuroscience behind that limitation. Why can't we cure the memory? Why doesn't the medication reach the actual root of the trauma?
To understand that, it requires looking at how a traumatic memory is physically encoded in the first place.
Take us back to the moment of trauma.
During a traumatic event, the amygdala and the hippocampus fire together in a state of sheer chemical terror. They encode a very specific, highly durable circuit known as fear conditioning.
So the brain is linking a neutral thing to danger.
The brain literally physically wires the environmental trigger, like a certain smell, a specific sound, a time of day, directly to a life or death biological response.
And that wiring is solid.
It is locked into the architecture of the basolateral amygdala through long-term potentiation.
It is etched into the hard drive. Our medications are just altering the software running on top of it.
The SSRIs and SNRIs suppress the fear output. They muffle the alarm bell so the patient doesn't suffer a full-blown panic attack every time they hear the trigger.
But the memory file itself, the neuronal connection that asserts the trigger is inherently lethal, is untouched by the medication.
Completely untouched.
So if the medication acts as a heavy, chemically dense fire blanket that smothers the flames of panic, psychotherapy is the water required to actually extinguish the fire at the source.
That is exactly right. Psychotherapy, particularly trauma-focused modalities like prolonged exposure or cognitive processing therapy, is the only mechanism we currently have to force the brain to rewrite that memory.
It forces the neuroplasticity.
Therapy forces the patient to confront the trigger while the prefrontal cortex is actively engaged, driving a process called fear extinction.
So they learn the trigger is actually safe now.
The brain lays down a new competing memory track that says, this trigger is safe. The medication simply lowers the volume of the amygdala enough so that the patient can endure the excruciatingly painful work of exposure therapy.
Without dissociating, fleeing the room, or suffering a psychological collapse.
Exactly. The med gets them in the chair. The therapy does the healing.
And this synergy between medication and therapy completely dictates our prescribing timeline and dosing strategy. Because we are waiting for 5-HT1A autoreceptors to downregulate and beta-1 receptors to internalize, the timeline is often the exact point where clinical trials fail.
Because the biological delay is agonizing for a patient in distress.
Oh, I can only imagine.
With an SSRI or SNRI, you are looking at 2 to 6 weeks just to witness the absolute beginning of a therapeutic effect.
Just the beginning.
Yes, the patient might notice their baseline anxiety is like 5% lower,
Ugh.
but a robust, full clinical response that requires 8 to 12 uninterrupted weeks at a therapeutic dose.
So imagine the clinical scenario. You have a patient who finally gathered the courage to seek help. You start them on an SSRI. They come back for their week 3 follow-up and say, this isn't working. I had a massive panic attack 2 days ago and I'm still not sleeping. I want to stop taking these.
If the clinician hasn't meticulously front-loaded the biological expectations, the patient will abandon the trial right then and there.
They will assume the drug is a failure and that their brain is just unfixable.
As a prescriber, you have to validate their suffering while holding the line on the biology.
What do you actually say to them on day one to prevent this?
You tell them on day one, you will not feel better next week. We are undertaking a massive structural remodel of your nervous system, and cellular construction takes time. The receptors are adapting, but they aren't finished yet.
Let's translate that timeline into a high-yield tactical prescribing strategy. When you are writing that first prescription, what is the exact methodology?
The absolute golden rule of trauma pharmacology is start low, go slow.
Because of that acute activation we talked about.
Yes, because the amygdala is already primed to explode. The acute receptor activation, hitting those 5-HT2A receptors, can cause a massive spike in panic and restlessness.
So if you start a PTSD patient on a standard depression dose,
Like 50 milligrams of sertraline or 20 milligrams of fluoxetine, you risk sending them into an iatrogenic panic state. They will drop out of care and never trust you again.
you must start at half or even a quarter of the standard starting dose.
Absolutely.
But the corollary to that rule is just as vital. Start low, go slow, but you cannot stay low forever. You have to aim incredibly high.
The failure to titrate up is one of the most widespread clinical errors in psychiatry.
People get scared of side effects.
They do. But once the patient demonstrates tolerance to the initial dose, you have to push the dose aggressively. The Maudsley prescribing guidelines are incredibly explicit about this. PTSD requires massive receptor occupancy to force downregulation.
We are talking big numbers here.
We frequently need to push fluoxetine to 60 milligrams, sertraline to 200 milligrams, or venlafaxine to 225 milligrams.
Because a severely traumatized brain has an immense amount of neurochemical momentum.
A tiny dose of 50 milligrams of sertraline simply does not have the pharmacological leverage to force the amygdala to rewire itself.
And once you hit that maximum tolerated dose, you hold the line. You give it an adequate trial of a full 12 weeks before declaring it a failure and switching mechanisms.
Prematurely switching medications every 4 weeks because the patient is impatient guarantees that they will never achieve receptor downregulation.
Aside from underdosing and premature switching, the other major pitfall we see constantly is treating the peripheral symptoms instead of the core neurobiology.
Oh, polypharmacy for symptoms.
Right. A clinician might prescribe an antihistamine for anxiety, a hypnotic for sleep, and a beta blocker for the heart rate, essentially putting Band-Aids over a bleeding artery without ever addressing the serotonin or norepinephrine dysregulation driving the entire syndrome.
Which brings us to the most dangerous Band-Aid of all in trauma prescribing. The elephant in the room.
The benzo trap.
The benzo trap. The over-reliance on benzodiazepines in trauma care is a systemic crisis. And to be clear, we understand exactly why it happens.
It's hard to watch a patient suffer.
A patient walks into your clinic suffering from severe hyperarousal, begging for relief. They might already be on alprazolam or clonazepam prescribed by a primary care doctor, and they swear it is the only thing keeping them alive.
Because in the short term, they are chemically correct.
They are.
Benzodiazepines aggressively enhance the binding of GABA to the GABA A receptor, opening chloride channels and massively hyperpolarizing the neuron.
It instantly shuts down the electrical firing of the amygdala.
It feels like a miracle to the patient.
But that miracle is entirely a mask, and the long-term cost is devastating. Every major guideline universally recommends against the long-term use of benzodiazepines in PTSD.
Restricting them strictly to severe acute crises for a maximum of 2 to 4 weeks.
The risks of tolerance, physiological dependence, and lethal withdrawal are well known, but in the context of trauma, there's a far more insidious neurobiological reason to aggressively taper patients off these drugs.
The disruption of neuroplasticity. We have to dive incredibly deep into this because this is the light bulb moment for so many prescribers.
To heal from trauma, the patient has to undergo fear extinction in therapy. They have to form a brand new memory that the trigger is safe.
And forming a memory requires chemical work.
The formation of a new memory requires active learning, which relies on a process called long-term potentiation in the hippocampus and the prefrontal cortex.
LTP.
Right. Long-term potentiation is driven entirely by the excitatory neurotransmitter glutamate binding to NMDA and AMPA receptors.
When glutamate binds to the NMDA receptor, it ejects a magnesium plug, allowing calcium to rush into the cell, which triggers the intracellular cascade that physically wires the new memory into the brain.
But when a patient is heavily medicated on a benzodiazepine,
The massive flood of inhibitory GABA actively suppresses glutamate release.
the neuron is hyperpolarized. That magnesium plug never leaves the NMDA receptor. The calcium never rushes in.
The new memory is never formed.
A patient can sit in exposure therapy for an hour, recounting their trauma, feeling completely calm because of the clonazepam, but their brain is physically, structurally incapable of encoding the safety memory.
They are chemically blocking the exact neuroplasticity required to cure them.
It is the ultimate chemical avoidance strategy.
You are hiding the fire alarm under a dense pillow instead of calling an electrician to fix the faulty wiring. The anxiety is masked, but the disease state is preserved in amber.
It actively prevents the psychological healing process.
Okay, so we know the timeline. We know we must start low and aim high. We know we absolutely must avoid the benzo trap. Let's get deeply tactical.
Let's talk specific drugs.
When you have that prescription tab in front of you, what exactly are you choosing? Let's break down the big three first-line agents, using Stahl's principle of matching the unique side effect and receptor profile of the drug to the specific clinical presentation of the patient. Let's start with the undisputed heavyweight champion of PTSD prescribing, sertraline.
Sertraline is commonly preferred as the foundational first-line agent, and the logic is incredibly sound. From a purely medical standpoint, it has the best documented cardiovascular safety profile among the SSRIs.
Which is vital if you are treating older patients, veterans, or those with comorbid metabolic syndrome.
But from a neurobiological perspective, sertraline has a unique mechanism. It exerts mild inhibition at the dopamine transporter, the D8.
It is an SSRI with just a faint whisper of a dopamine boost built into it.
And that subtle D8 inhibition makes it a brilliant, highly targeted choice for trauma patients who present with severe atypical depression features layered over their PTSD.
Like what kind of features?
If the patient is suffering from profound psychomotor retardation, hypersomnia, where they're sleeping 14 hours a day, significant hyperphagia, or cognitive flattening.
That little bit of dopaminergic activity can provide the precise spark of energy and concentration they need to get out of bed and attend therapy.
Exactly. It also has a relatively clean cytochrome P450 interaction profile, making it a safe foundational drug when you need to add other agents later.
But what happens when the baseline anxiety is so severe that sertraline isn't enough? That brings us to paroxetine.
Paroxetine.
This drug is fascinating because it carries FDA approval for PTSD, and if you look at the treatment algorithms, its efficacy data is incredibly robust.
Yeah.
But clinically, it is a massive double-edged sword.
Paroxetine is highly effective, precisely because its receptor binding profile is so chaotic.
It's messy.
It doesn't just inhibit the SERT pump, it also has mild anticholinergic actions, specifically binding to the muscarinic 1 receptors, as well as weak norepinephrine transporter inhibition, and it even inhibits nitric oxide synthetase.
Because of those anticholinergic and NOS inhibitory properties, paroxetine is intrinsically sedating and calming right out of the gate.
Which sounds like exactly what you would want for a patient whose nervous system is vibrating with hyperarousal.
Right. It forces them to relax a bit.
It is highly effective for that specific symptom.
Right.
But the cost of that complex receptor profile is a massive side effect burden. It is the heavy artillery of the SSRI class.
What are we talking about here?
The M1 receptor affinity causes significant dry mouth, severe constipation, and cognitive dulling. It is notorious for massive weight gain, and it carries the highest rate of severe sexual dysfunction in its class.
So furthermore, paroxetine is a potent inhibitor of the CYP2D6 enzyme, which means it inhibits its own metabolism.
The pharmacokinetics are completely nonlinear.
Exactly. And because it has an incredibly short half-life combined with no active metabolites, missing even a single dose triggers a brutal, immediate withdrawal syndrome.
We are talking about severe vertigo, brain zaps, nausea, and rebound panic.
So the clinical calculus is intense. When do you deploy paroxetine, and when do you keep it in the holster?
You deploy it when a patient's insomnia and anxiety are so utterly debilitating that they need that intrinsic sedative effect, and only after cleaner agents like sertraline have failed.
And when do you avoid it?
You absolutely avoid it in patients with any history of medication noncompliance because the withdrawal syndrome will traumatize them further. And you avoid it if the patient is highly sensitive to weight gain or sexual side effects, because those issues will guarantee they abandon the treatment.
You are constantly balancing efficacy against adherence.
Nice.
And if the patient fails the SSRI class entirely, that brings us to venlafaxine, our strong SNRI option.
Venlafaxine is an incredibly versatile tool because its receptor affinity is entirely dose-dependent.
Explain that for us.
At lower doses, around 75 milligrams, the affinity for the SERT pump vastly overpowers its affinity for the net. So at 75 milligrams, you are essentially just prescribing a very expensive SSRI.
But as you push the dose?
As you push the dose to 150 milligrams and eventually to 225 milligrams or higher, it radically engages the norepinephrine transporter. That is when you trigger that massive surge of dopamine and norepinephrine in the prefrontal cortex that we discussed earlier.
So let's talk real-world application. How does a prescriber know when it is time to abandon the SSRI strategy and switch to venlafaxine? What is the specific clinical trigger?
The primary trigger is residual, unyielding hyperarousal, and profound behavioral avoidance.
Give us a scenario.
Consider a patient who has been on an optimized dose of sertraline at 150 milligrams for 12 weeks. They come into your office and report that the depressive anhedonia has lifted, they're no longer crying every day, and they have the energy to shower and go to work. The serotonin has done its job on the mood.
What?
But they are still checking the locks on their doors 15 times a night. They still cannot walk down a crowded grocery store aisle without their heart rate spiking to 130. They are still jumping out of their skin when the phone rings.
The mood is better, but the autonomic hyperarousal and the fear-driven avoidance are untouched.
That is the exact moment you realize the serotonergic lever alone is insufficient. You need to forcefully engage the norepinephrine system.
You cross-titrate them to venlafaxine, aggressively push the dose to 225 milligrams, and begin the long process of forcing those beta-1 and alpha-1 receptors to downregulate to finally exhaust that hyperarousal.
This level of clinical reasoning is exactly what separates basic prescribing from advanced psychopharmacology.
But we have to pivot our focus to a population where even these advanced algorithms frequently fall short. We need to talk about special operations, veteran-specific prescribing considerations.
Because the literature is abundantly clear that the combat veteran population does not mirror the civilian trauma population.
The clinical presentation is fundamentally altered by the nature, duration, and severity of the trauma.
Right. A civilian might experience a single horrific acute trauma, a car accident, or an assault. A combat veteran has often lived in a state of mortal terror 24 hours a day for 9 to 15 months at a time.
The resulting neurobiological adaptations are profound.
The combat veteran profile is characterized by an immensely high baseline of hyperarousal and a deeply ingrained, structurally hypertrophied noradrenergic tone. Their locus coeruleus has physically adapted to constant war.
And the treatment algorithms heavily reflect this physiological difference. The standard interventions just do not hit the same targets with the same efficacy.
The meta-analyses consistently show that our gold standard SSRIs, even sertraline, demonstrate statistically weaker efficacy in male combat veterans compared to civilian trauma cohorts.
Why is that?
The massive continuous overdrive of the locus coeruleus is simply too powerful for a purely serotonergic intervention to overcome. The system is too flooded. These patients frequently require much stronger, direct, and aggressive targeting of the norepinephrine system right out of the gate.
And the most immediate debilitating manifestation of that locus coeruleus overdrive is the destruction of sleep architecture through combat nightmares.
It ruins their baseline before the day even begins.
Exactly. If a prescriber is only focusing on daytime anxiety, they are completely missing the battlefield. If a veteran is spending 8 hours a night trapped in visceral, terrifying replays of combat, waking up drenched in sweat and physically exhausted, their nervous system is already maximally dysregulated before their feet even hit the floor in the morning.
Daytime therapy is useless if the night is a war zone.
This is where we must introduce highly targeted, off-label prescribing, specifically the use of prazosin.
Prazosin was originally developed as an alpha-1 adrenergic antagonist to treat hypertension, but its application in combat PTSD is one of the most vital pharmacological discoveries in recent decades.
It requires understanding the physiology of normal REM sleep. Let's break that down. What normally happens in the brain when we dream?
In a healthy brain, when you enter REM sleep, which is when dreaming and emotional memory processing occurs, the locus coeruleus essentially shuts off. Norepinephrine levels drop to near zero.
So you can dream about wild things but stay calm?
Exactly. This allows the brain to process intense emotional memories without triggering a physical sympathetic nervous system response. You can dream about something frightening, but your heart rate remains calm.
But in the combat veteran...
In severe PTSD,
Yeah.
the locus coeruleus fails to shut down. It continues to fire, creating massive surges of norepinephrine during REM sleep.
And those surges trigger the nightmares.
These surges flood the brain, forcefully bind to alpha-1 receptors, and trigger these violently intense autonomic nightmare replays. The brain is processing the trauma, but the body is reacting as if it's actually happening again.
So by administering prazosin at night, we are utilizing its alpha-1 antagonist properties to physically block those receptors in the central nervous system.
We are placing a chemical shield over the receptors. The locus coeruleus might still misfire and dump norepinephrine into the synapse, but the neurotransmitter cannot bind to the alpha-1 receptor to initiate the nightmare cascade.
The physical intensity of the dream is blunted.
This drastically restores normal sleep architecture. The veteran finally achieves restorative REM sleep, which inherently lowers their baseline autonomic hyperarousal the following day, making them far more capable of engaging in their daytime psychotherapy.
It is a brilliant, highly specific pharmacological intervention, but treating this population also requires navigating immense comorbidities.
Yes, complexity is the rule, not the exception.
A combat veteran rarely presents with isolated PTSD. They almost invariably present with overlapping traumatic brain injury, or TBI, as well as substance use disorders, often alcohol use disorder as a form of self-medication.
And the presence of those comorbidities completely shreds the standard prescribing rulebook. If a patient has a history of TBI, their brain is profoundly sensitive to cognitive slowing and anticholinergic effects.
So paroxetine is out.
Prescribing a drug like paroxetine with its heavy M1 affinity to a patient with a TBI will severely exacerbate their cognitive fog and memory deficits.
And the presence of a substance use disorder completely unequivocally rules out the use of any benzodiazepines.
Absolutely. You cannot, under any clinical justification, prescribe a highly addictive, cognitive dulling, respiratory depressing agent to a patient with a traumatic brain injury and a history of heavy alcohol abuse.
The risk of lethal overdose is astronomically high.
And the suppression of neuroplasticity we discussed earlier guarantees their PTSD will remain chronic. When treating veterans, you are mandated to use medications with incredibly clean cognitive profiles. You lean heavily on sertraline, aggressively titrated SNRIs, and targeted agents like prazosin, while avoiding anything that compromises brain healing or introduces addiction liability.
It all comes back to precision medicine based on the raw neurobiological reality of the specific patient sitting in your clinic. Which brings us to the core takeaway for today's deep dive. If you carry only one principle back to your practice tomorrow, let it be this. PTSD pharmacology is an exercise in nervous system regulation, not a mechanism for a cure.
It regulates, it doesn't erase.
Every prescription you write is an attempt to turn down the volume of a screaming amygdala and provide the chemical fuel to wake up a dormant prefrontal cortex. You are weaving a neurochemical safety blanket so that the patient can finally tolerate the incredibly demanding, painful, necessary work of trauma-focused psychotherapy.
The clinical mindset must always be that you are creating the biological conditions required for psychological healing. The medication is merely the bridge. The therapy is the ultimate destination.
But before we sign off, we want to leave you with a final, highly provocative thought, something to consider as you look toward the future of your practice. We have spent this entire hour detailing the complex neurobiology of how our current medications only suppress the fear output.
They muffle the alarm, but that fear-conditioned memory remains hardwired in the basolateral amygdala.
What happens to the field of psychiatry when we finally crack the code on drugs that can actually rewrite the memory file itself?
It is the most thrilling question in modern trauma research. We are standing on the precipice of a frontier called reconsolidation blockade.
Break that down for us.
The clinical theory is that every time a memory is recalled, it becomes temporarily unstable or plastic before it is reconsolidated back into the hard drive. Researchers are exploring whether administering specific agents like MDMA or ketamine during a highly controlled, targeted therapy session can induce a profound state of neuroplasticity. The goal is to retrieve the traumatic memory, render it unstable, and then either rewrite it entirely without the paralyzing emotional pain or chemically block it from being reconsolidated back into the limbic system at all.
We are talking about a paradigm shift from indefinitely suppressing fear with daily pills to potentially erasing the visceral emotional weight of the trauma entirely in a handful of sessions. It is a fundamental reimagining of the brain's capacity to heal, and we will absolutely be dedicating future deep dives to exploring that exact neurobiological frontier.
It's going to change everything.
Next time, however, we are going to zoom in on the granular day-to-day mechanics of the clinic. We will be analyzing the precise nuances of cross-titrating sertraline and paroxetine, managing those complex side effects, and navigating CYP enzyme interactions.
It will be a highly practical, deeply technical session tailored exactly for your daily prescribing challenges.
Thank you so much for joining us for this deep dive. Take these foundational neurobiological principles, keep the image of the fire alarm and the security guard in mind, and trust your advanced prescribing logic in your next clinical encounter. Until next time.